Yes.
You see now. Perfect. Right. Hello, everyone, to this MedTalk with Kathrin, and today Karin. K and K, we used to say. It's even poetic. Yes, I want to welcome Karin today to my MedTalk. I invited her because she and we have kind of the same background. And as soon as we met through Noor, I think it all started. Our very first MedTalk with Noor and Mark. We instantly felt like I don't know, like friends, I would say. And then we met in France, and it just feels really nice to talk to you, Karin. And now today I wanted to give you all a sneak peek into a nurse's breaking room. And let's talk some nurse. But Karin, let's introduce yourself a little bit. Who are you? What did you do? What do you do now?
Yeah. Thank you. Thank you for the invite. And I can only agree in what you just said about us meeting and instantly having the click as former nurses. And I think we share a lot of passions for communication and care and everything. So that was immediately there. Well, I'm Karin. I am almost 48 years old, but I still feel 38, of course. And I am I'm still a nurse, but previously I worked as a nurse, as an oncology nurse. For many years. I think altogether I've worked in nursing for 22 years. And now I am, as you call it, a medical communicator.
Right, yeah.
Now I have a degree in translation. I'm a sword translator for Spanish and English into Dutch and the other way around. And I specialize in medical translations, and since last year also in linguistic validation.
Yeah, crazy, a lot. But I know you also do legal translations, right?
Yes, I do.
Yes.
Yeah. I have because I'm a sworn translator, and I also completed a course in criminal law translation from Spanish, and in the past. So that's what I do as well. But it's not. I think it's only the criminal law. Unfortunately, is 5 to 10% of my work, I think.
Yeah, and that is only Spanish Dutch, or is that also English Dutch?
No, that's well, it can
Only.
be English to Dutch, but I have these clients in Spain that usually send me the projects from Spanish to Dutch. Yeah.
And how did I when I think of you, I think of a Dutch lady. I always forget that you're also a Spanish lady. So kind of like, where does the Spanish come from?
Yeah, no, I don't really know where that comes from. Maybe I have this old bloodline in Spain. I don't know, but it began with always feeling comfortable in Spain.
Yeah.
Whenever I touch Spanish ground, then I feel really at home. And I have this in the Netherlands as well, but and I was always, because I love the Spanish language. So it all started actually with me doing all these Spanish courses and just trying to master the Spanish language. And then finally I was introduced to the how do you say that, to get the degree in translation for Spanish, and then that all just rolled. So, but it's a passion for Spanish, and I always wanted to, because when I was 18 and I had to choose what I was going to do, I wanted to do a lot of things.
Yeah.
And
so when you were 18, you decided to become a nurse first.
Yeah.
Why is that?
I had to choose.
Yeah.
And I loved. There were a lot of studies I would like to do, but the nursing was the what appealed to me the most at that time. And the funny thing is that at that time I thought I would study Spanish, and then I thought no, because then I will be. I was 18 at the time, and then I thought I will be either a teacher, a Spanish teacher, or a translator now. I
Yeah.
will never be because I thought no, I don't want to be a translator.
Interesting.
Yeah,
Interesting. I
that
never had the
felt
thought of being a translator or yeah. Languages appeared much later in my career than nursing. Like for me, it was always clear I'm going to do something with medicine. Like when I was 6, I knew already what I wanted to be. And I always knew that I don't want to be a doctor. I always knew that I wanted to be a nurse. Just because I like caring for people, and still I'm very interested in the medical, language as well. Like just how doctors talk. I found that fascinating. So you became a nurse when you were 18, and how long did that education go? Like the base education?
the base education. Well, I because I was one of the lucky ones that I could I had to apply for that role, but I had this role in the hospital in Amsterdam where I could be studying and working at the same time.
Oh,
So
perfect.
yeah, that was really great because then I could apply what I learned immediately in the hospital.
Yeah.
So and that was a 4-year study.
Yeah. And then during that time, you found yourself most interested in oncology, or how did you get to oncology?
Well, when I finished my my studies, my basic nursing studies, I already worked the last period of that studies. I worked in the gynecology and urology ward, where there were a lot of oncology patients with mostly gynecological cancer. And I already completed a few courses in oncology there. And I even wrote my thesis at the end of the study about an oncology subject, gynecology and oncology combined. So, and then I was just searching for a way to dive into that oncology more, because I found that really interesting, because it's a really complex specialization in many ways, in not only in the physical way, but also because it involves so many layers of where people are built off, you know.
Yeah.
So that was a big interesting thing. And then I got into contact with someone at the Netherlands Cancer Institute, at the other hospital that is associated with the Netherlands Cancer Institute, Antonie van Leeuwenhoek ziekenhuis, it's called. And they had this internal specialization course.
Yeah.
Well, yeah, it's a 1.5-2 year course. So and then I applied for that, and I was, I could start there.
Wonderful. Did you? I was always fascinated from cancer as well, and also HIV. When I was 8, I think I heard the first time about HIV. And when I was 10, I had my first presentation in school about HIV, because I was scared but also fascinated by the topic. Which year are we talking about when we talk about you when you started your specialization course? What year was it? About?
I think that must have been about 2001 or 2.
So that's almost 25 years, about 25 years ago.
Yeah.
Right. Yeah. That is when I started nursing.
Sorry.
No worries. No worries.
Well, also
Um,
that was a position and a study in one. So
yeah. So you worked and you studied.
yeah,
Yeah. Yeah. Like the previous education program. Yeah. It's the same. It's the same in Germany. Actually, you learn like that. You study. You don't go 5 years to university to become a nurse. You have like the dual
yeah,
education, we call
yeah,
that.
cool. Yeah, yeah.
And I think that's the best way to really learn something instead of just at university. Here in Sweden, they have like 5 years university and then they are nurse. It's like, okay, you should see some patients before you. I mean, they do have practical training a few weeks a year, but still.
Mm.
I was going to say, yes, I was always fascinated in cancer. But when I first worked on a cancer ward, it was the one with glioblastomas, and it's a lot of young men actually. And I couldn't cope working only with cancer because I felt I took them home. And also the patients that I still have in my mind is always cancer patients, quite young cancer patients, and their journeys and how heavy it was for me. I mean, I was really sad very often, and I call that my nursing trauma, and something that I think is very underestimated by people who are not in the healthcare space, because every doctor, every nurse, every physiotherapist, everyone working there has traumas. We experience a lot of very serious stuff, and I wonder, how do you or how did you cope with that? Like working for years only with oncology patients.
Yeah. Well, I think because I ultimately I experienced the same thing as you did, but I think, yeah, I don't know why I just did that, but I experienced the same things, and of course, and that builds and builds and builds, and eventually it led to me after years deciding that I wanted to do something else with my nursing career, and I eventually I made the shift to the emergency setting, which is the acute care, the ambulance, which is really short and less invading in my. But yeah, I how did I cope with that? I think there were a lot of tricks. Of course, one is that you're just trained for that. You're trained, and you have your colleagues, and you have the briefings, and you have the people caring for you in the work setting as well, because that's in that hospital where I worked, that was really of a high standard to care for each other, because
Okay.
you experience this much, because it's the Netherlands Cancer Institute, and the hospital only has cancer patients. So
Exactly.
then this particular hospital was really keen of caring for their people, the people that had to work every day with all these emotional and heavy burdens.
Yeah.
And so that helped me a lot. And I also developed some, yeah, like tricks or coping mechanisms, I think. For instance, I remember I told you once, but all the other people didn't hear the story. But for me, wearing my uniform
Yes.
was kind of a defense mechanism.
Yeah.
Because when I was in my uniform, I arrived at my work, I changed into my scrubs, my uniform, and then I went to work, and then I was the nurse, I was the HCP, and I was the one professionally doing my thing. And what when I, for instance, went home and I arrived the next day, I would arrive again for another shift at the hospital, and I parked my car in the parking lot, and I was still in my own clothes. And then I would bump into a family member of a patient of mine. Those were the difficult moments for me.
Yeah.
Because then I was not the professional. Then I was Karin, just parking her car,
Yeah.
Just, so yeah, I think those the uniforms, the scrubs, the professional, the things that make you a professional also get into your head, and then you have this kind of barrier. But of course, I have my we say that in Dutch. I have my graveyard here. I have my and all my experiences and all my the patients that really got to me, and the stories, and that there are numerous stories that got to me, of course.
Yeah, definitely. I completely hear you. Sometimes I think I could write a whole book about stories. This is also why I started my blog at some point.
Yeah.
To kind of work through those patients that stick with you. And the scrub thing, I never thought about that. But once you said that to me the first time, I was like, yeah, actually, I wish I would have seen it that way when I was nursing still.
Mm-hmm.
Because I think that could have changed a lot I was a very good nurse. I think I can say that, but I wasn't good at leaving it in the hospital,
Yeah.
And funny, I just got goosebumps when you said that you went to the emergency, like to the acute care, because this is exactly what I did.
Yeah.
I've been in the emergency care for 7 years, and I really loved it. I mean, there was tough stuff as well. There were stories, but many stories I felt like I really helped them. They got better and they could even go home. So it was very grateful. You got a lot back in regards of I don't know, positivity in health, or like actually sick care systems.
Yeah.
So yeah, it's always fascinating. I do think back, and I really loved my job. I really loved what I did, even the also the oncology. What really hits me is that you worked there like 25 years ago, and this is when I started my professional nursing career. And back in those days, the cancer treatment wasn't as how do you say, successful as these days. So having cancer in the past, like 25 years ago, you were like, oh, well, I'm sorry. But luckily these days the cancer research is so much further. And how do you experience that? What do you think? I think it's more like many cancers can now be seen as a condition, like a chronic condition, instead of a death sentence. Do you see it the same way, or do you still feel like like you did 25 years ago?
No, of course it depends on the type and the cancer and the localization of the cancer. So, but I do when I think back of that time, because it has developed. Of course, it has developed a lot, and what strikes me is that now, because I have had some personal experiences with people in my environment having cancer and being treated for cancer, that especially treatments have evolved.
Yeah.
In a very good way. For instance, when people received chemotherapy, almost everyone would get really, really sick.
Yeah.
And now, of course, they still can get really sick, but there are a lot of medicines and a lot of treatments of the side effects that just reduce all that. No, not all, but it reduces it better. So I think, yeah,
all those targeted therapies and immunotherapies, I hear so many good stories. I keep following people on like cancer patients on Instagram and stuff. And I have this one German guy. He has stage 4 lung cancer. It's been 3 years now. He's been given like 3 months in the beginning. But then he got on a targeted therapy, and he never had to do chemo, and he is still here. And also a young guy, I think he's my age. Or there's another cancer patient, stage 4 from the US. He has been running a marathon under targeted therapies because he doesn't have chemotherapy. So I think there is something great going on.
There is definitely. Yeah.
I mean, obviously not for everyone, and obviously it's still a very serious condition.
Yeah, it is.
Yeah.
And I'm not, because I'm not an oncology specialist or something, or expert. So I wouldn't know about numbers and figures and percentages. But I only see what I see is that it appears that mainly side effects and everything can be treated much better, and that people can just have more quality of life being treated. So
one short note, one short question. How involved you were also doing some clinical trial studies with your patients, and this is also the reason why I ask you to co-write something for the book I wrote with Keith, Clinical Trials, Science Field Recruited. Karin shared her perspective of why patients would join a clinical trial. And I would like you to just shortly explain to us, why do you think they join trials? It's not hope, you said.
No, it can be hope. But it's not the main. From my experience back then, I think it's much more than hope. I think it's not all the people that I met then, and all the patients that were participating in the trials, they were basically, maybe there was a little component of hope in their motivation, but I think it basically was the fact that they had the choice to participate. That they, when you get this sick, all things just happen to you, and there are all people advising you, telling you what you should do. You are diving into this roller coaster of treatments, of appointments, of all things that are happening to your body and to your mind, and to your roles are shifting in your family, with your doctor. Everything is changing, and you don't have any control over it. And if you are presented then an option to do one thing that you do have control over, and that might even benefit your situation or your or other people, but you have the choice to say, yes, I'm going to participate in this, and I'm going to give it my all. That is a really strong motivation for people to not just go lie down and wait for what is going to happen, but this one thing is something that they can do.
Yeah.
So, and that's my experience from a lot of people that I met back then in clinical trial setting. And also, the feeling of knowing that, at least back then, knowing that it will probably not benefit, or even slightly benefit the position or the situation they're in, they just don't want to lay back and say, okay, my life is over. I just want to do something. And of course, not everyone wanted to do something, but yeah, there will be a really big motivation, and also the feeling of having a little say about what's happening to your life. So
yeah. How did you have you been a part of the informed consent process? Because it's not just a document, it's actually a chat with the doctor as well to get informed consent. Have you been part of this?
Mostly the informed consent part was already completed before because I was working on the ward they would be admitted on to receive their treatments.
Yeah.
Their monitoring and everything. So.
Yeah. All right. Right. How do you, or did you feel about the communication from the HCP side to the patient side? Did you feel like you were translating the doctor's language to the patient language, or did you think the doctors cope well getting onto the same level? What do you think?
Well, my experience there in that hospital is really good. It's really good because I think the communication there is already, well, at least when I worked there, but we already established that it was 25 years ago that I started there. But yeah, because it's so specialized and it's so niche onto the complexity of the cancer patient in all its layers. The people that working there are already focused on, okay, we should address all that layers. So we shouldn't make it. We should try to make it as little complex as possible. So my experience there is, well, it is that we are all trying to speak the patient's language, and that's a really fascinating thing because you have to be able to read the room also, and just to from the first moment to try to find the communication method or mode that fits that person. So
yeah, everybody has a different headspace or brain capacity receiving such a strong diagnosis, right? Yeah. Some are very clear, some are very like, okay, I have a goal and this is where I'm going, and some are completely lost.
Yeah, or scared, really scared.
Yeah. And scared, yeah, absolutely. And then out of fear, you get numb, you get like into this spiral in your head, and then most patients I talked to, when they got their diagnosis, like very fresh, they said after hearing the words "you have cancer," that they can't remember what else the doctor said, which is why I always say this actually needs to have a second appointment, or when you get in there, always take a friend with you or some family member, someone who is a bit more clear after hearing the diagnosis, who can then remember what the doctor actually said and guide you and stuff. Something that I actually did when I had end of last year, this moment when I thought I had breast cancer, because I was, after the mammogram, I was called back into the hospital, and only with the note, yeah, you need to come back. And this was like 2 days after, so it was very urgent between Christmas and New Year. My head was just like going crazy, and I couldn't even drive there, so I took my friend with me, and I was so glad I had her there, because after the whole process with the biopsy and all this stuff, she actually told me what happened, because I was so in my fear. I always had that cancer fear, I kind of was born with cancer fear. I don't know why, but it completely blacked me out. And I know so much about cancer, but in that moment, everything was gone, and I was just in fear, So
But
I decided, I had a really bad doctor when coming back to the communication. He was really mean, like cold, and I live in Sweden, for those who don't know. I live in Sweden, but I was lucky that he was a German, so he could even speak German to me, because that was the main reason why I took my friend with me, because I said, okay, my third language, in this state of mind, I need someone who can like really understand the language. But then he was German, but it didn't make it better. He was such a cold, not nice person, to say the least. And then I thought, okay, he's gonna get a copy of my book, How to Speak Cancer,
yeah,
in all 3 languages, because he was, oh God, no. And this is what I experienced as a nurse very often, that doctors have distance to people, to normal speaking people.
Yeah, I think that I think, because I've been thinking about that, but for me, I think one of the biggest qualities you can have as a healthcare provider, nurse, being physiotherapist, being whatever healthcare provider you are, is to be able to try and impersonate into the person you are. You're talking to a person, not a patient, not a subject. You're talking to a person, and this person has all these emotions. And of course, when I just told you that my experience in that hospital, but that's not how do you say that? That's not representative for all the hospitals, because this is not a general hospital. It's a oncology specialized hospital, and people are trained there to try and see the whole picture and the whole person that is sitting in front of them. But that's the main thing you have, the main quality you have to have, just to try and impersonate. And that's also really dangerous for people like you and me, who take in all these impersonation and just take in all these emotions. And so, yeah, that's the, it's just the thing to try to
find your balance.
Find a balance and keep seeing the person that's in front of you, because it's not the 20th person that's coming in this week for a scan or a conversation or an examination. It's just someone who has just heard 2 days ago that they might have had that they might be really sick and really ill, and
or they are further in the process, and every CT is still or every PET CT, PET scan, whatever, is still very frightening, because you never know what the result is going to be.
Everything is frightening. I am, because that's the funny, no, it's not funny, but it's a striking thing. As a nurse, I always, because I could be a pain in the ass for my colleagues or other disciplines, because I was always just going beyond for my patients.
Yeah.
And that was just in really little things, because if I thought that someone had to wait too long in a waiting room to get a scan or something, then I would just go and call and say, okay, we have to speed this up, because this person is really anxious about being in the scan, and every minute he has to wait, it is just adding up and adding up. So all these things, I was always just trying to make the road as less bumpy as possible.
Yeah, I feel you.
A really tiny side note to my personal situation: when my father in 2017 and 18 had to be treated for cancer as well, I was there like the gatekeeper for him. And I was also, because if someone at radiology would have a big mouth to him, or just treat him like a number, or just patient number 76, I would just freak out for that. So and I think, but I think that's really important, that patients people with cancer or with every other disease need someone besides them on a professional level that is just trying to make the road as smooth as possible. So yeah,
it would be great to have a patient advocate for every patient, right? Or having like a patient advocate sitting in the hospital who is there for patients when they say, okay, I need someone. If they don't have relatives or friends they want to involve in the process, then there should be someone sitting there and being available for them to talk to, right?
Yeah, also, and that's what we're going to, what we can do with communication as well, because communication is really important. How you communicate.
Yeah.
The meta communication, not only what you say, but what you say non-verbally. It's also it's so important. But what we can offer as medical communicators, we can offer. We can just contribute to that, and your book is also contributing to that.
Yeah. You were the second reader of the Mark, who is here too. You were the second one ordering the book. I remember that. Maybe you would like to share your thoughts, because I thought you were so sweet. Your thoughts were so sweet. So and hearing that from you as an oncology nurse, it really boosted my confidence in publishing the book, really, and going further with the book, because I don't know, maybe you want to share your thoughts yourself.
Well, because I ordered the book. I ordered the book when we met at MedTranslate, because you didn't speak a lot about the book before MedTranslate, right?
No, it was just published a few days before we met there.
Oh yeah. But you
hadn't. And I didn't dare really talking about it,
No, you didn't really promote it before.
No.
I
not at all, actually.
No. So then I ordered it, and I just loved it, because and that's when I knew that we would have this professional click, because it's so important that all these terms, all these medical languages is translated into the not only simplified. It's not about simplification. It's just about getting the click with the reader and with the patient and the people that are ill and they have the cancer. So I loved it. And I think I recognize a lot of things in the book, and
I was very anxious.
Blood, sweat, and tears that you poured into this. I can just see that. You can just read that.
And it comes from the heart, because as the people who know us now also know, this whole communication thing is not just a job for us. It's just like nursing. It's not just a job, it's a passion. It's something that we both are so passionate about. And we want to help people to understand their condition, right? And I'm really glad you were so positive about the book, because after you said that about the book, then I started promoting it, because if an oncology nurse signed it up, then I was like, okay, now I can promote it, and I felt much better about it.
But it's because it all falls back to the making the road as smooth as possible, because you can also destroy a lot with communication, with bad communication, or not bad communication, but just communication that doesn't fit the recipient.
It's like speaking another language.
Speaking another language, or just saying one thing and saying another thing non-verbally.
Right. Just look someone in the eyes is such a big difference. Or if I'm leaned against you or someone else, is such a big difference in communication, right? Already.
Because it's a really when I make the link to my nursing experience, just a tiny example. Once I had this patient, this person. He participated in a clinical trial, and part of the protocol was that he was to be punctured to get blood drawn 6 to 8 times a day.
Wow.
But yeah, and then you must imagine that you have this ward with 18 rooms, in which 18 patients that have all that all have to be blood drawn 6 to 8 days times a day. So, but this man had a really large anxiety and needle anxiety. He has this big fear of needles, and he has he always just almost passes out when he be punctured. But he decided to participate anyway. So his desire to participate, not because he thought he would get better, but just to participate in this trial to help other people. In his example, it was to help other people. It's larger than his fear of needles. So if you then go into that room and say, okay, so we're just going to do the puncture, and then blah, blah, blah. And then this man would just freak out, because it was not just a puncture. It was 6 times a day, a really large thing to overcome for him.
Yeah.
And so then communication and language is so important. And it's in really small, tiny things. So yeah, and I think it's something we should be aware of, that really small things like, which word am I going to use? How am I addressing this person? Am I calling someone a subject?
Yes, please not.
Or am I calling someone a participant?
Yeah. Because or a partner, even
team member.
Yeah. I mean, this is what it is, right? This is what we wanted to achieve with the book about clinical trials, is that we are all partners in there. Yeah. We as linguists, they are participants, and also the clinical trial investigators and the research stuff behind it. We are all a team, we all have the same goal, right? And this is how we should be treating each other. And also from the patient side, to understand the pharmacy side is, I mean, yes, they want to earn money, but also what isn't in mind often is that maybe out of 20 possible trials, one medication makes it. And this is also a job designed to fail, and you have to be really resilient working in this atmosphere as well. Something that most of the people don't have in mind when they think about clinical trials, that most of the trials are actually failing, but still we learn something out of it. Learning out of your mistakes or out of things that don't work also give you hints to things that will work, maybe. Yeah. Or, at least you don't need to try it again. Yes, to the puncture example you said, I wondered, I had that picture also in my head, is in the emergency room we had patients, also often cancer patients, who were getting worse and worse, and then they came in, maybe they were dehydrated or whatever reason. And they had, like, for those who don't have worked with patients so far, cancer patients have very bad veins very often, because the chemos, they destroy all the veins. And it was already very hard to take blood if they don't have a port. I don't know, how was did your patient have a port here?
Yeah,
Yeah.
most of them did. Yeah.
Yeah, that makes it much easier. But still, in the ER, some doctors or nurses weren't experienced, so they would try to get blood in the arms or legs or feet or hand. And I was like, oh gosh, sometimes 8, 9 punctures, another doctor and another one trying. And I was like, okay, you guys need to stop. And the patient was just lying there waiting for it to be over. Didn't have any energy to interfere, to say, stop, I can't bear it any longer, you know. And this is when I stepped in, you know, what you said before, you were always stepping in for your patient. It's okay, you guys can't just leave the patient and use the port. I mean, if they have a port, then get someone who knows how to use it, you know. Well, I think we could exchange a lot of stories. I must say that most of the stories that I carry with me, I don't dare to share because they feel very hard for someone who is not in there, because I have a lot of pictures in my head and they are not often very pretty. So I don't dare to share them in this like official space. But anyway, is there something that you want to let us know as a closing note, something that is very important for you that you want to share with us, our listeners, to always have in mind, maybe when it comes to medical communication?
Yeah, that I think the main thing is that you're always talking to a person, and that you have to that you have to, because you also have to do with protocols and with preferred language, and with linguistic validation we have to fit the concept to make it concept equivalent, the translation. So you have this restraints as well. But I think as medical communicators we just have to be like the bridge between protocol, between medical jargon, and the people that are being communicated to. So no, it's communication is both ways, but you know, you have to try and be the bridge.
Yeah.
I know, because you just said something about the pictures in your head. That is actually what is helping me now in my work a lot.
Yes.
Because I can translate and I can create text in my language, and I know what this side effect looks like.
Yes.
I know what this complication looks like. I know what the treatment looks like. I know the color of the chemo that is running into the veins, and I know the different emotions that someone can have to go through in the process, because I have seen them. I have had them in my hands, and it's not necessary. It's not a necessity to have that experience, but it helps me a lot. It helps me a lot, because I see this text and I think, oh yeah, and I think of this in this patient. Oh yeah, that was the, and then it helps me just put it in the right language, I think.
Yeah. I completely relate. I completely relate. I went to my mentees. I always say, try to picture a patient sitting with you on the desk. Oh, not on the desk, but at the desk. Maybe on the desk. Getting a bit uncomfortable. But yeah, I always have that patient with me, and not just a patient. We keep saying patients. Actually, I always have the patient and the caregiver, like the family member, someone who is caring for them, because they are just as important. I think the ICFs, we write them also for them. You know, they will read it with the patients. So actually, I would like to address them often as well in the leaflets or whatever we write and translate. but I completely relate. And I also say to my mentees that it might be very beneficial to go and have a 1 week or 2 week or however long you can manage hospitalization. Do you say that in English? Like a practical training in a hospital, and maybe in a ward with your specialty, like in this case, oncology or cardiology or something, just to have exactly that.
Yeah.
See the patient and get a feeling for it.
And again, it's not because you can be a brilliant medical translator without having any HCP experience, of course. But I'm just from my own reference. That's what's helping me, and it's also I am so grateful that last year that I met all these like Noor and Mark and you and all these people, and I was introduced to the linguistic validation specialization course Noor is giving, and it all fit like a glove, because now I can, because the one thing I missed during my medical translator career is just having the patients. I didn't have my people to to work for. Of course, I did have them in my mind when I was working, but I didn't have contact with people and that I was helping. And now, through linguistic validation and cognitive debriefing, I get to combine everything, and it all just fits into place and like a glove. So I'm really grateful that my path went there, and now I'm just so much enjoying my work I'm doing now. So yeah.
Oh, that's beautiful. Yeah, it's definitely on my to-do list, and I feel the same. I'm missing this patient contact and real talks to patients, which is also a reason why I have MedTalks, because then I can talk to patients and HCPs and other colleagues. And yes, well, now actually we hit the hour.
Yeah,
almost. We did. I want to thank you from the bottom of my heart. I always love to talk to you, you know that. And thank you for sharing your experience with us. And for everyone listening, Karin and I, we are planning something great. So stay tuned and listen to the news on MedTalks. Hit the follow button if you haven't yet. And we'll keep you posted. Thank you again for the day, Karin.
Yeah, thank you. And I hope it all made a bit of sense, because when I start talking about my work and my passions, and then I'm just getting lost. So I hope I have.
No, it was perfect.
I have made a bit sense of it.
Does anyone have any questions? I forgot to ask. Anybody, any questions, any comments, anything to share with us before we leave? Oh, you seem to be clear. No questions, Karin. Thank you very much.
Yeah.
Perfect.
I enjoyed this.
It was very sweet. Well, then have a nice day, everyone. I will stop the recording now.